interesting questions. The first question is NGS needed for all metastatic cholangiocarcinoma cases? And what shall we do in our hospital as a standard of care? So the question for Dr. Ale and also for the whole panel.
Yes, Dr. Mirbat. I think now currently in we received the request from our oncologists in our hospital to do the NGS for the cholangiocarcinoma, and yeah, we don't have any hesitation really to perform the next generation sequencing for them. Because especially when most of the people are usually with advanced, they come with advanced stage. So really we don't have any hesitation of performing that. So I think it's recommended really to do.
So how many genes you are doing in real life and practice? It is 35 or 23?
Yes, so usually what we are doing in our lab, the one which I mentioned, the 58 gene panel, the one which has the 38 mutations and the gene fusions as well, because it covers most of the genes that encountered in gallbladder cancer. But if you are asking me for hepatocellular carcinoma or even for pancreatic, maybe I will consider the larger panel. We send usually as a send out for Foundation One Medicine.
And the IHD1 and the FGRF, do we have any cases recorded in the cases you did? Because as pointed out by Dr. Abu Alfa, that it's a small percentage, about 5%. So in our population, how do you see?
Yeah, I agree with Dr. Alfa. It's yeah, I didn't see so far on the cases, which also is one number of cases that we did the NGS. I didn't come across the IDH1 mutation, IDH1, IDH2 mutations.
Perfect, thank you. We have a very interesting question. If you do have a patient with cholangiocarcinoma and HCC, how you treat this patient? And this question for both Dr. Alfaya and Dr. Abal as well. Dr. Alfaya, can you please recommend?
The question is, if you have a HCC and cholangiocarcinoma,
how you, yeah.
So both actually are having a poor prognosis drugs. We tend, when we have a mixed histology, to track the more aggressive type of tumor. So in this condition, HCC has a more options of targeted therapy. So my approach is really to proceed with treatment as HCC. And when there is a progression, I would really rely on the biopsy again to look for the NGS and look for targeted therapy. If there is no targeted therapy for that, then I will go for chemotherapy.
Thank you. Dr. Ghassan, so if you do, we don't have any targetable mutation, what do you can do?
No, that's a great question, and I'm very happy this question was brought up. So as many of you already have seen, we published many times on the combination of the cholangiocarcinoma and hepatocellular carcinoma. By the way, just to put it in perspective, data do differ between about 5% up to 15% of the patients might have combined HCC cholangiocarcinoma. Interestingly, in most of the time, the cholangiocarcinoma is the driver, and in other words, HCC happened to be there. And the sense of priority of the therapy should be for the cholangiocarcinoma. And as such, even without mutation, chemotherapy-based treatment will be the appropriate one. We published beforehand on gemcitabine, cisplatin, and sorafenib, with the sorafenib, of course, to apply for the HCC component. But now we tried, even without really any reported data, but just by experimentation, using gemcitabine, cisplatin, and lenvatinib. And by all means, it's an appropriate option of therapy as well. The most important is just be careful always that you cannot give full dose of the therapy. You probably need to do a certain dose reduction. And as such, for example, for lenvatinib, instead of 12 milligram, I would do 8 milligram.
And it's tolerable to have chemotherapy plus sorafenib because every aspect has its own toxicity as well.
That's correct, but also there is certain interaction. And as such, when we did our study, the sorafenib dose that we could only give was 400 milligram. And with the lenvatinib, we're able to manage with 8 milligram.
Perfect. And there is another question the limit of bilirubin level, specifically that, as Dr. Turki pointed out, that most of the patient presented with the jaundice and the bilirubin level is high. So what is the limit so we can start for the patient either treatment? This question for Dr. Abu Alfa.
So if I'm sitting for an exam today, I will probably say no more than 2. But if I'm not sitting for an exam, I would say probably the tolerance is going to be way higher. Intriguingly, the driver is not the cisplatin. The cisplatin I'm not that worried about. It's more about the gemcitabine. And interestingly, can you push for gemcitabine even for bilirubin up to 6 or 8? And I'm not saying here like be totally kind of easy about it, etc. But we did that before. Usually, we have to remember that when the bili is that high, and in other words, there's no specific adjustment for the biliary drain that could occur, i.e., now we're looking damage. Sadly, the situation is not good to begin with. As such, it becomes like really a last resort effort. Remember, a patient who's coming first-line therapy, never tried anything, to be able to reverse the course by giving some chemotherapy to make them better. It's a little bit far-fetched, but nonetheless, you can give that attempt. Admittedly, in 20 years of experience, the only time I was able to reverse course was among maybe a couple of dozens of patients, maybe once. That's it. So I would say, yes, it is doable, but we have to be very thoughtful about that. It might not gonna necessarily benefit per se. So it's something to really use very thoughtful judgment and of course to run it case by case.
Perfect. We do have a question by Dr. Garni, please.
Thank you all for the excellent talk. I just have one question to Dr. Abu Alfa. I have one patient, it's really not easy to get the medication here since it's just recently approved. So I have one patient, I was able to get the ifosfamide for her. This is a case of IDH mutant. And what I noticed that this patient has really very significant and severe fatigue. So my question is, how common you see this side effect in your clinical trials and how you manage the dosing for these patients?
Yeah, thanks so much, Dr. Garni. This is a very important question because number one, I would like, before I answer the question, I would like to bring a very important point. We intriguingly have seen that patients in the Middle East might have more IDH1 mutations. To be fair, this is something we did not really study or analyze further because remember our referral patterns depends who end up coming our way. But this is a great invitation for all of us to do together probably in understanding of the genetic alterations that can occur specifically in the Gulf or in the Middle East as a whole, because interestingly, we've seen IDH1 mutation probably more present than in other places. With this said, the fatigue is not really the common therapy, the common therapy event related adverse events that we would expect with ifosfamide. Ifosfamide has been rather very well tolerated, and people do very well with ifosfamide. It's very easy to take. So could be the certain particularity or exceptions, of course, but it has not been the common thing. The more common ones, as you remember, we spoke about them at length at ESMO in Barcelona 2 years ago, is really diarrhea at the same time the elevation liver function test. But of course, it's not like it won't happen, but yes, you're right, it's a little bit less uncommon.
Perfect. We do have a question. If we do have, you are putting in the clinical trials some patients who have CR. So for a case of cholangiocarcinoma with CR, do you will go for surgery or just only maintain with treatment, which is very rare even for CR?
I'm sorry, you're addressing anyone of us specific or?
Yeah, the question for you, Dr. Hassan, please.
Oh, sure, of course. So yes, you're right, actually, Dr. Marhous, the CRs are rare, but of course, it's a great celebration if we have to CR. Remember one thing, if there's a complete response, it means there's no disease. And as such, I would not jump to any surgery because we don't know what we're gonna cut. And maybe there's nothing to cut anyway. And number two is, it is probably more important question about like, when do I stop therapy altogether? And I would say you have to be very nervous over here. This is what probably I would push at least for extra 6 months of therapy before I make a declaration, okay, we're gonna stop treatment. I would say probably it happened. It's not common, but in the few places where it happened, I know that pushed for therapy at least for 6 months and sometimes even a year. And patients, however, lost amazingly well, and they stay without disease for a long while. This is an exception. I always tell patients, please don't aspire for it, don't look for it. But if it happens, we'll say, thankfully, it's here, we'll take care of it.
Last question for Dr. Ale and Dr. Turki as well. So we know that patient with MSI high, they have a possibility for CR and the durable response as well. But Dr. Ale, you presented as well that in the patient with cholangio and biliary, they can the PD-L1 can rely. You can rely as a predictive. But in GI, usually we are relying on MSI, not on PD-L1. So how you can explain this? And we need the comment of Dr. Turki. You are muted, Dr. Ale.
So the data that we have, as also Dr. Ghassan discussed, is the pembrolizumab seen to be effective in the MSI high DDMR tumors. Nivolumab seen to show some benefits, especially in the enriched PD-L1 groups. Dual IO did not really show that these are predictors. So I believe in the GI malignancies, we have to rely on the MSI until we have a very good data about the PD-L1 predictability for such treatments.
Perfect. Do you want to comment, Dr. Saleh?
Yeah, I think I agree with Dr. Turki. And I think I found a lot of studies really talking about the correlation between the two, like the PD-L1 and the microsatellite instability, and over the tumor mutation burden as well. Like the more you have these tumors microsatellite unstable, you have more tumor mutation burden. And they found also that you will get also more PD-L1. But I think it should be tailored based on the practice and according to the system, the organ system.
Finally, I would like to thank you all for excellent presentation and excellent response for the questions. And thank you for all the attendees and their excellent questions as well. It was a very interesting and exciting session for Totally Unmet Need. Thank you again and have a great day. Thank you.